Now we have all the tools needed to examine how health insurance affects the demand for healthcare and ultimately how it affects healthcare prices, utilization, and healthcare expenditures. Graphically, the effect of a change in coinsurance, for example, the portion of the bill paid out of pocket by the patient on the demand curve, is treated differently from other factors that influence demand, and let's see why. Here we have the original demand curve for 100% coinsurance. This is demand without insurance, where the individual pays the entire healthcare bill out of pocket. Without insurance, the consumer faces a price of P for office visits, and where P intersects the individual's demand curve, that determines the overall level of utilization of office visits, and in this case, it would be Q. So a coinsurance rate of C, shown here, AC of 0.5, lowers the price paid out of pocket by the patient to C times P. So they're now facing a lower price, which has fallen from P to C times P, and quantity demand rises accordingly from Q to QC. This is a movement along the original demand curve, the 100% coinsurance rate demand curve. But in effect, what's happening is the demand curve is rotating clockwise around the quantity axis intercept, and that's because in practice, we still have the price of healthcare P, but now utilization has increased from Q to QC. So total expenditure rises from P times QC, and the new demand curve demand is with a 50% coinsurance rate. This is the effect of the demand curve, or the demand that healthcare providers are facing, and it's now more vertical, or in other words, demand is less price elastic. Note that Q max is the quantity demanded when the price of healthcare falls to zero, or when we have a 0% coinsurance rate. And when we have a 0% coinsurance rate, that leads to further outward rotation of the effective demand curve until it becomes vertical like Q max. So facing a 0% coinsurance rate, demand is now perfectly price inelastic. The insured individual will be willing and able to pay any price for the maximum quantity of healthcare services demanded, because the insurer will be covering all expenditure, P times Q max, and the effect of price paid by the patient is zero. This suggests that more generous health insurance coverage, that is, in the case of lower coinsurance rate, will lead to greater utilization of healthcare services and also greater healthcare expenditure, holding all else constant. And this is what we see empirically as well. Some of the famous Rand health insurance experiment, for instance, those patients with a coinsurance rate of 0% went to the doctor's office more frequently and had higher hospital admission rates, and also filled more prescriptions than those patients with higher coinsurance rates. Now, let's examine the general market effects of health insurance coverage using a model of supply and demand. Previously, we were taking the healthcare price P as given, but now we'll be modeling it as determined by supply and demand in the market. Here we have an upward sloping supply curve and a downward sloping demand curve, originally shown by 100% coinsurance. A lower coinsurance rate from 100% to 50% paid by patients leads to an outward rotation of the market demand curve. This will lead to a rise in equilibrium price of the healthcare service in question from P0 to P1, and also an increase in the quantity of healthcare services provided from Q0 to Q1. Total expenditure will also rise from P0 times Q0 to P1 times Q1 in the equilibrium. This suggests, in general, holding all else constant, a lower coinsurance rate will lead to a less price elastic or more price inelastic demand curve in the market. It will also lead to a higher equilibrium price for the healthcare service in question, a rise in healthcare service provision and utilization, and also a rise in total healthcare expenditure. Let's consider the effects of another cost-sharing requirement, this time a copayment. Copayment is a payment made by a patient for each office visit or for each prescription drug. If we have this original demand curve representing the individual's willingness to pay for health care for each office visit, we'll see that utilization will be determined where the copay intersects the demand curve that tells us the quantity Q of services demanded by this patient. But in effect, what happens to the demand curve is that it becomes perfectly price inelastic above that copay amount. And so the insured patient will not be concerned about the actual price of the healthcare good or service of question, and quantity demanded will only be a function of the copay and not the actual price. As an example, the copay for a visit to a dermatologist may be $40. While the dermatologist fee may be $300, the patient only pays $40 and doesn't actually see the dermatologist fee of $300, and the insurance will cover the remaining $260. So if a patient visits a dermatologist twice a year, as determined by where the copay intersects the demand curve, the patient would pay copay times Q out of pocket. And in this case, it would be $40 per visit multiplied by 2 visits, or $80 out of pocket. And the insurer would pay the remainder of the 2 visits, or $360 times 2, for $520. In this chapter, Burnell presents 2 concepts related to health insurance and the demand for healthcare, and we'll dive into each of these in much greater detail later in the course when we cover the demand for health insurance. First, a few definitions. Adverse selection refers to the idea that certain individuals have characteristics that are associated with a higher demand for healthcare. These individuals tend to choose health plans with fairly generous benefits, whereas people who have no or fewer health issues tend to opt for basic coverage. The idea is that many individuals know more about their health than an insurance company does, and those individuals use services more frequently than the insurance company anticipated. That means the insurer may raise premiums the following year to compensate for the higher than anticipated health expenditures. And as we'll see later in the course, this could have implications for health insurance coverage as well as for the premiums paid by insured individuals. A second concept presented in this chapter was what we call moral hazard. And this is the idea that people who are protected from risk may behave differently from those who are exposed to risk. So the provision of health insurance coverage, for instance, may induce an increase in utilization that was not expected by the insurer. Specifically, moral hazard can manifest itself in 2 ways, as put forth by Burnell. The first is that health plan members might increase their demand for goods and services, even unnecessary ones, if they're out of pocket. Cost is low if the coinsurance rate or the copay is low, for instance. The second is that insured individuals may become complacent about their unhealthy or risky behaviors, which could lead to more health problems that require more health care. And so both of these concepts could shape the demand for health care because of how they affect the insurance markets and individual behavior. Here ends the presentation for Chapter 5, Part 4.